First and foremost, this is the domain of conservative therapy. Only in exceptional cases, which I'll talk about later, operative treatment can also be considered. After the diagnostics that I just explained, we will decide on which therapy we can recommend to the patient. It has been proven that one can load in a way that is adapted to the pain, with the ankle joint in a brace or, in serious cases, in a walker. If you suspect that more than the ligament apparatus, i.e. outer ligament or inner ligament apparatus, is broken and the syndesmosis could be affected, a walker can be applied, which ensures that the range of movement in the ankle joint is almost eliminated, and the ankle joint can rest better. In the further course, or in the case of less serious injuries, you can also resort to an orthosis. The modular concept has been established in recent years, which means you can adapt the orthosis depending on the phase of the injury. This means in the first phase, when I still have pain, swelling, and above all, limited mobility, then the most rigid orthosis possible would still be needed. If it then goes to the second phase afterwards, the reality is significantly improved, the patients can walk without pain, they can then adapt the orthosis bit by bit, which means you can give less stability. In the third phase, when it comes to slowly regaining everyday fitness and also the ability to play sports, you only need a little support. Ankle braces work in such a way that they try to support the natural healing phases of the body. So you want the ligaments and structures of the ankle to heal without being exposed to any re-trauma or risk factors. In the first phase, it is important to reduce the swelling, which is quite possible with the orthosis by incorporating a material that increases the compression so that the swelling can be reduced. If you want to prevent twisting in the acute phase, it makes sense to have a supination protection. That can be achieved with a strap, for example, that you pull over the orthosis, which immediately limits forward movement of the talus. When the mobility is better and the stability has also improved accordingly, then you can still remove the lateral stay, which is also the purpose of the modular system. Another advantage of these orthoses is that they can also be worn in shoes. Whether or not you put a sock under the orthosis is up to you, but it is usually the case that most patients wear a sock under their orthosis. Of course, it is also important that in the acute phase, the orthosis can be removed without any problems for body hygiene, but it should also be worn at night to further reduce the swelling and so the ankle doesn't regain swelling overnight. The orthosis is of course only as good as it is worn, so the best orthosis is of no use if the patients do not accept it because it is uncomfortable, for example in shoes. Worth noting in this regard is that the full stability and the best functioning of the orthosis is only achieved if it is actually worn in the shoe, and not flip-flops or sandals, but in normal stable shoes. First and foremost, you can't make the aftercare the same for everyone. It's very individual, depending on the healing process, and we have to orient ourselves very much to the status of the patient. That is, if we have someone who still has a lot of swelling, we would like to reduce this swelling, and then we can gradually improve our movements, etc. If we have a good load capacity of the ankle joint, have regained good mobility, and also do not experience pain, then we can go on to add early functional training according to physiotherapeutic instructions. There are, for example, exercises that you can also do on your own at home. You can stabilize the outside of your foot against the wall, for example. You can regain the everyday ability to climb stairs. Here it is very good to use the handrail so that you put weight on the ankle in a controlled manner, and then gradually the function and normal mobility in everyday life can be restored. This is a burning question for many amateur athletes. It is usually the case that you can do endurance sports again after 4 to 6 weeks, such as light jogging, for example, while pivoting sports, that is, everything that is fun and involves a ball, can be resumed after 8 to 12 weeks, depending on the pain. What would certainly be a mistake is that one exercises with pain, or even worse, takes painkillers just to be able to practice the sport. This should not be done under any circumstances.
According to worldwide medical research, 20 to 40% of ankle injuries have residual instability after 1 year. International Guideline Police, published in 2018, replaces rest with optimal loading to prevent chronic ankle instability. Contemporary Acne, Peace and Love, published in 2020, further encompass the continuum of care, outlines the importance of education, addresses psychosocial factors to enhance recovery, and reduce high percentage of re-injuries and chronic ankle instability. Protected ambulation with an air stirrup brace inside shoes is recommended. The air stirrup functions as an edema pump, accelerate circulation and healing, enable early return to function. Anti-inflammatory medication should be avoided to prevent negative effect on long-term issues, healing, and opioid addiction. Use of ice is also being questioned, since the cooling and numbing effect is only on the skin surface. Controlled cryocompression delivers the coldness deep down to the joint, where the pain is. The intermittent compression is also a very important form of optimal loading. It is also recommended to be used pre-op and after physiotherapy. Education. It is essential to educate patients and stakeholders about the high prevalence of ankle injuries and CAI. A comprehensive functional rehabilitation, injury prevention programs are needed. While injured part is well protected, stretching and strengthening and body coordination exercise should be performed early to prevent joint stiffness and avoid atrophy. Pain-free aerobic exercise should be started early to increase circulation and boost motivation. NMES can be combined with open chain exercise immediately post-injury to optimize vascularization and enable neuromuscular training. This helps to avoid drop of neuroplasticity after injury and trying to rebuild it much later. Once patients regain range of motion and strength, they can proceed to more advanced exercise to restore proprioception, coordination, and endurance. NMES can be combined with optimal loading exercise while patients still in walker. Regaining natural mobility enables patients to go back to full body exercise and improve optimism. Happier patient, better outcome. Photobiomodulation promotes vascularization at the injured site, therefore avoiding the risk of stagnation at the subacute stage, helping to move from inflammation stage toward proliferation stage. Class 4 laser has significant effect on pain management, opening the therapeutic window for early exercise. Kinesiophobia, joint instability, body compensation are still the common challenges for return to sport. NMES has a role as a neuromodulator. When NMES is superimposed with functional training, it helps to translate improved muscle strength into functional movement during the game. The acronym Peace and Love aims for favorable long-term outcomes and treat the person with the injury rather than the injury of the person.